Yeah, I'm going to share with you the patient's chief concern, but it'll become very obvious to you by first sharing with you that one aspect of his chief concern was shortness of breath. And so I think it's a great opportunity to just practice that space. So Glenn, with just that information alone, when you hear shortness of breath, what thoughts cross your mind?
Um, okay. Just shortness of breath alone, or in relation to um. So I'll be thinking maybe either problems in the airway, or the vessels, or a neuromuscular junction, or the um basically anatomical.
Yeah,
um um my differentials will be anatomical, either airways, neurons,
good.
neuromuscular junction, and all that.
Good. You seem to have taken the lung and broken it down into its anatomical functions. And one way you could also do it is break it down by the two purposes of the lung. The two purposes of the lung are oxygenation, which is air alveoli and vessels. And the other purpose of the lung is ventilation. So the lung does something very simple. It moves air in and out. And then in addition to moving air, it moves air for one purpose, to exchange stuff. And so is there a gas exchange issue or a motion issue? Superb. Simi, can you think of any other organs that take space in your mind except the lung for shortness of breath?
Maybe I think we can also think about heart. Patients with heart failure can have shortness of breath that will be more so on exertion. And we can also think about any diaphragm issue that may be either due to trauma or a neuromuscular junction problem, or a problem in the peripheral nerves, or something compressing on the diaphragm from above or below.
Yeah, wonderful. And you can see that ultimately, like if you're trying to think of shortness of breath, your ultimate localization may be very, very complicated. You might have a tracheal obstruction, you might have a brainstem lesion, you might have acute hemorrhagic shock and anemia. So it's really, really hard to capture all of shortness of breath in one sentence. But fundamentally, there's going to be a problem either in the lung, in the heart, or in the blood. And Khashar laid it out very, very well. Khashar, do you want to say it out loud?
I believe this was either an academy session or
Yes.
rapid fire. I don't remember correctly, but we basically made a schema that was similar to how we think about AKIs, pre, post, and intra. With
Exactly right.
with intra being, yeah, just the things that I wrote down.
Yeah, I mean, the truth is most of us do revolve around the concept of the lungs being the center of breathing. And I think reminding ourselves that we often fixate to them, but there's things that happen after them and before them can really, really help anchor you when you're thinking for shortness of breath. So I think it's helpful to stay big picture because shortness of breath was just one half of this patient's chief concern. The other half was dizziness. And so, yes, the mental exercise will be to see how these two things interact. So now that we've built shortness of breath, let's build dizziness again from a very big picture view, not the individual diagnoses, but rather the larger categories. So how could I not come to our two neurocritical care folks to talk about dizziness? Maybe in the same order. Sarah, we can kick off with you. What thoughts cross your mind when you hear dizziness? Big picture.
Big picture, I
Yeah.
kind of group dizziness into what I'm going to call like true dizziness, which is like
Okay.
a vestibular in the brain dizziness.
Yeah.
And in that category, I think of things like vertigo or BPPV, things that are within inner ear, stones, that type of thing, or something like vestibular neuritis, where you have inflammation of the inner ear. And then I think of things like stroke that can be in like the posterior circulation of the brain. You can end up with dizziness as kind of the manifestation of that. And then I'll separate the other bucket where I think of things like pre-syncope, which are not dizziness, but people might describe it as dizziness to you if you are like not fully teasing out exactly what they're talking about. And in those individuals, you're thinking about things like orthostasis, you're thinking about cardiac causes of poor perfusion. You might be thinking about things like anemia or lung pathology, things that are causing them to be, shortness of breath, pre-syncopal, that category of dizziness.
Love it. I love it. That's awesome. Sam, how does that word intersect your current approach? Where do you stand on dizziness?
I definitely want to echo everything Sarah said.
Mhm.
I love that approach. I think I would also consider, what are some sequela of respiratory problems that could cause dizziness? So sort of like you said, hypoxia, a low flow state from cardiac pathology, anemia, or alkalosis,
Yeah.
other sort of metabolic sequela of a respiratory problem,
Right.
hydrocephalus, if you're hyperventilating to try to combat increased intracranial pressure,
Excellent.
that can cause dizziness for sure. Pressure on the brain stem. I mean, there's so much there. I feel like shortness of breath and dizziness are both
Yeah.
such huge concerns with a very broad differential, and
Yeah. I
the ways that they intersect makes it a little more specific.
Yeah, that's what I'm talking about next. So ultimately, both of you are spot on to some very fundamental principles, which I'll try to simplify even further to tell you that dizziness is dizziness is a sensation that is either mediated by structural problems in the brain or the nervous system, or actually the blood that is bathing the brain. And you might find yourself localizing a peripheral vertigo or a central nervous system problem, or realizing that actually the issue is not in the brain at all. And if you transplanted that brain and put it in somebody else, it would be just fine. It would not feel dizziness. And so what is it about the blood? It's either a quantitative deficiency, so there's not enough blood getting there, as Sam just said about a low flow state, or there might be a qualitative issue, meaning that there's something in the blood itself, not the quantity, but the quality of it, that the brain doesn't like. Be it that it is empty of glucose, and that brain doesn't like that, or empty of hemoglobin, the brain doesn't like that, or as just Sam said, the deficiency of carbon dioxide or alkalosis, the brain doesn't like that either. In large part because what alkalosis does is actually vasoconstrict the vessels going to the brain, and so you don't get enough blood anyway. And that's something you want to do when you've got too much pressure in the brain. So I think this model of thinking about these two things is not going to be actionable in the ER, meaning that, or in anywhere. When you're walking up to a patient, you're not going to be like, I wonder if this is a brain problem or a blood problem. But these models can help you see the intersection more clearly. So, dizziness, big picture, lung, heart, blood. Dizziness, brain, heart, blood. With the heart being the quantitative issue and the blood being the qualitative issue. So when you lay them out like that, gosh, the overlap is effortless, right? There's a cardiovascular unifier here. And so when somebody comes in and says, "Hi, doc, I've been feeling short of breath and dizzy for the last 4 days," and you're mimicking real life, the patient is, I'll tell you, walked in, sitting in front of you, sitting in the triage chair, and now you know the probability of a brain problem is way lower because he's also short of breath, and the probability of a lung problem is way shorter because he's also dizzy. And so you're focused on the blood or the heart, or quite simply, you can just say, I'm focused on the blood, either quantitatively, a perfusional issue, or qualitative. And so the goal now is to try to get the diagnosis as quickly as possible. So Magnus, you're there, and you're getting your history. What do you want to know?
Yeah, so I would want to know for how long has that been going on? I don't remember if you said that already.
4 days.
4 days. And then I would also like to know the past medical history, especially if he's known for any like cardiac diseases or have any risk factors. and also if he's on any medications right now. And then I also think I would like to know if there are any associated symptoms like chest pain or all that stuff, or if he had bleeding from the gastrointestinal canal or something like that, would also be good to know. And then I would also like to know if there are any worsening or alleviating factors. I guess that he is dizzy while he walks around, but is he also dizzy at rest? Would be interesting, for example.
Unfortunately, he has so many background medical problems that he has no grasp of how many or what's relevant. He asks him, he's like, "Oh, doc," he says something along the lines of, "I have just so many problems, I can't quite tell you." He has no chest pain. He feels dizzy all the time. It's not made any worse when he stands up. He just feels dizzy constantly. So, Nicola, what progress have you made with Magnus's questions? Where are you at now?
Yeah, it's a tough one. I was just thinking, how could I make progress quickly in this situation? I think generally also looking at dyspnea, I think just checking is there hypoxemia can help us a lot. Walking the patient to maybe unmask hypoxemia, which might not be present while the patient is not exerting itself. Looking for signs of heart failure. So patient with dyspnea who has JVD is in a different patient than someone who has a depleted, jugular pressure. Potentially looking for conjunctival rim pallor, and then I guess like Magnus already told us, taking a thorough history, looking at any pulmonary disease, any cardiovascular disease, any issues with the blood, any bleeding episodes, and of course any neurologic disease. But like you said, if it's a chronic disease, I would be less worried about, a vascular acute issue. So I wouldn't be as concerned as of this being like a posterior stroke, which is a do not miss diagnosis in somebody with acute dizziness, but this seems to be more prolonged. So those are my thoughts.
Yeah, excellent thoughts. I'll give you the two pieces of information you asked for in a moment. I just wanted to echo that the purpose of this exercise is to arm you with what we talked about last time with our two patients with back and hip pain, about discharging both of them in 2 minutes. You can't discharge this patient in 2 minutes, right? But part of what I'm going to try to help you to do is to ease the cognitive load of not having so many thoughts. Meaning, if your patient is giving you enough clues that you can start to focus in on a narrow subset, why would you remain broad? And I think that the emphasis on having a broad differential diagnosis is one that is very wise for folks who are early in their training. But the goal of taking these 30 minutes is that you have a less broad differential diagnosis afterwards, because you see the key characteristics that allow you to zoom in. And what I'm proposing to you is that the combination of shortness of breath and dizziness is a very, very narrow space. I have never seen somebody with a stroke report shortness of breath, ever. I've never seen somebody with, COPD exacerbation report dizziness. Never. Now, of course, if there are so many overwhelming features of those two diagnoses, you would discard that. But the idea of somebody being dyspneic, lung, heart, blood, and dizzy, brain, heart, blood, means this is a heart, blood problem until proven otherwise. So here's the fun part. His sat in the room, counterintuitively, is 92%. And he has no signs of heart failure at all. His lungs are perfectly clear, and he has no JVT distension, no edema. And I'll tell you, because we have this easily, weighed him, his weight is the same. I'll just tell you the rest of his vital signs to round it out. His blood pressure is normal. His heart rate is normal. And his respiratory rate is normal. So we're going to do a 5-minute breakout room. And I will tell you that you have the opportunity to have the diagnosis in your hand in the next 2 minutes. That's going to be hard, but that's the point. Talk it through yourselves. Give me a moment to summarize two things. What you know so far about the patient and what we've learned so far about dyspnea and dizziness. So what do we know so far? Is this is an elderly man who has a lot of history, but he doesn't know it. Medical history, he doesn't know it. Who's coming in with 4 days of shortness of breath and dizziness, who was found to have no evidence of heart failure, no chest pain, no orthopnea, and whose vital signs are relevant for an isolated hypoxemia to 92%. So when we come back, I'd love for you to share your thoughts about what you might want to do as next diagnostic tests. And I'll give you the hint that you have the ability to get this test back in usually a few minutes. Okay? All right. See you all very soon. Okay, let me just pull up everything. Okay. So Simi, what was the conversation like in your group? What did you all talk about?
We thought about a lot of different possibilities. We were thinking whether it can be something like methemoglobinemia, or it can be a heart issue. We should definitely get an EKG because sometimes arrhythmia can cause it. We also talked about it being a shunt issue or
Yeah.
pulmonary hypertension contributing to it. So we did discuss multiple things.
Yeah, excellent, excellent, superb. Thank you for sharing all that. We'll put it all together in a moment. Elena, what was the conversation like in your group?
Yeah, I was hanging with the nerds Samantha and Farah, and they were talking about many different toxidromes that could potentially cause this, which I have no idea about. Also, we talk about methemoglobinemia and salicylate toxicity and things like that.
Yeah.
And Samantha pointing out that the ECG would, for example, be a very quick test that we could get to like spot something like a micro obstruction in the heart from heart failure or like an arrhythmia. I think, I think my thoughts were that I think I would start with the hypoxemia and sort of anchor on that and go through my differential for hypoxemia, like either like rarely it's like from the outside, but then it's really often comes down to a diffusion problem and sort of try to overlap it with the dizziness. And I think I would sort of end up with a micro obstruction in the thoracic cavity somehow. And I think I was thinking a lot about pulmonary embolism for this patient here, but I think it rarely causes hypoxemia unless it has led to other complications, like an infarction or pleural effusion or something like that. So I wonder if with the patient like not knowing their like vast medical history, this could be a good presentation of something like SCAPE. Where there's a lot of like diffusion problems, which could lead to like hypoxemia, but also like an increase in the thoracic cavity that could make the patient feel dizzy.
Wonderful. Great. Absolutely great analysis. Magnus, what was the conversation like in your group?
Yeah, it was really interesting. Kashaya brought up the idea that there could be some metabolic problem in the blood. We also talked about methemoglobinemia or other like forms of hemoglobin that Austin mentioned you can detect in less than 2 minutes, which was the clue here. Yeah.
Excellent, superb. The reality is, here's what we're talking about, okay? You guys see this? No? Okay. Oh, sorry, I shared the wrong one. I'm trying to share it. I'll share this in a moment. I just want to anchor us first in. We're either having a quantitative issue, blood not moving, either because there's a rhythm issue or a blockage. And all of you have brought this up. Or a qualitative issue. And the qualitative issue can be that there's no hemoglobin, or there's something wrong in the blood itself.
Rabih, we are still seeing the same screen as before.
Oh, really? Mhm. So wait 1 second. Sorry. Oh, okay. I see what the problem is. Sorry. So this is kind of to help. Let me try again now. Thank you for letting me know. Okay, yeah, here we go. Combination of dyspnea and dizziness. Cardiac or blood. There's really there's only really 3 causes of cardiac shortness of breath. There's something wrong with the rhythm, there's something wrong with a pump or heart failure, or there's a blockage. Patients with heart failure are never dizzy. Ask me why later. Massive venous congestion, orthopnea, very rarely report dizziness. So we're either here or here. And all of you, it's amazing, all of you were able to name these things and examples of all these things along the way. Question is, take for a moment how short this list is. Because if you are walking into a room and using the whole differential diagnosis of dyspnea and the whole differential diagnosis of dizziness, and instead of seeing how little overlap there is, you're holding on to every single possibility. How weighed down you can be by that, when in reality, the things that occupy both spaces is a microscopic sliver of those 2 spaces. And so the question is, as you all said, how do you bring this to life? And you bring it to life by realizing what tests you have in real time. And so, oh my gosh, sorry, I'm having a real hard time with screen sharing too. So you bring it to life by realizing that you can get this stuff very quickly. EKG in him, normal. A point of care hemoglobin right at the bedside, normal. An ABG with co-oximetry shows a met hemoglobin level of 25. The answer to this case comes from a very simple observation, that his hypoxemia is shocking. Why? The lungs are very, very rarely the focus of conversation in a patient who has dyspnea and dizziness, as we talked about. And so when you're so surprised that you're finding fundamentally what is a pulmonary issue, impaired oxygenation, with the little side caveat that the impaired oxygenation may be because the heart is doing bad things to the lung, but those patients with heart failure will never tell you they're dizzy. So you know that's off. That's when you immediately doubt the validity of that O2 set, that it's not real, it's wrong. And that's the fundamental clue to this case. So I think we haven't heard from Mengyu. So Mengyu, I'll give you the hardest question of all. Can you guess what medication he's on? He's on a medication that is notorious for doing this. And I'll tell you the full story in a second. But curious to hear what analysis you have of triggers for methemoglobinemia and what medication the patient might be on.
Yeah, let me think.
Yeah.
Certain like those oxidizing, like nitrate, or
Yes.
light certain antibiotics, like I have on my list, like Bactrim or Dapsone, or local anesthetics, but I don't get any history
got
on
it.
that. I mean, nitrate or like nitroprusside is like
Mhm.
I mean, that is more in the cyanide toxicity, maybe not.
You got it. Yeah, he's on Dapsone.
mm,
So what is his history? He has cryptogenic organizing pneumonia, is on steroids. And because he's on steroids, he has a Bactrim allergy and was placed on Dapsone. Dapsone is, in the United States, Dapsone is the most common cause of methemoglobinemia. And so maybe we can just build our illness script for methemoglobinemia real quick. I think of all of us, Sam is probably the most likely to see it in the ER. So I'm curious, what is your what's your working knowledge of this condition?
I've never seen it yet. I have a feeling I will.
Oh, yeah.
I feel like this is, I mean, sort of like this patient came in, I would expect dyspnea, even, but they may not look dyspneic. No, we wouldn't see like tripod positioning, tachypnea, increased work of breathing, because they're actually oxygenating. Their lung diffusion is fine. There's not a lung problem, like we said. So they'll report subjective shortness of breath without sort of objective correlates. And then dizziness because they're not able to perfuse their tissues, including the brain.
Yep.
And then I would also expect in some patients some degree of cyanosis, kind of depending on the level of the methemoglobinemia. And then usually some sort of, again, medication trigger. I'm not sure if she has any ideas. Medication trigger or something. I feel like the classic thing I always think about is a recent trip to the dentist.
Yeah, awesome. Superb. Superb. Yeah, all those things are spot on. You mentioned the presentation, mentioned the risk factors, the diagnostic test is you have to do a co-oximetry. Nicola, do you happen to know how we treat methemoglobinemia?
Metal and blue.
Yes, excellent, excellent. So in most instances, the key thing is actually stopping the medication, which I know you know. But in people who have a mild to moderate methemoglobinemia, that's sufficient. But if they're symptomatic, like this patient was, you give them methylene blue. Does anyone know the contraindication to giving methylene blue? Or you can't give it? Nicola, do you know? No, I just had.
Is it, shit, I heard about this. Is
Yeah.
it G6PT
Yeah.
or is it, yeah?
Yes, exactly right. Exactly right. So the most common underlying vulnerability for methemoglobinemia is G6PD deficiency. So let me just elaborate on the idea that most people who get methemoglobinemia do so because the trigger, i.e. a medication or exposure, is sufficient. But if there's something inherently predisposing you to get it more so than other people, it's the enzyme G6PD that is supposed to protect you from reactive oxygen species. And so herein lies the paradox. Every single time you're about to treat methemoglobinemia, you have to ask yourself, well, wait, this patient population is enriched for G6PD deficiency. Am I going to make this worse? And so that should loom large on you. And so that's often why it's a little bit stressful to give patients with methylene blue, with methemoglobinemia methylene blue, because you might just make them much worse. The reason you make them much worse is methylene blue is a great reducer of our reactive oxygen species, but it requires first to be acted upon by G6PD. And if that doesn't happen, then it makes things worse. So you have to be very, very careful. And that is why actually we did not give him any methylene blue and just let him take a day or two to wash it out. Because he, unfortunately, unlike most people, had not gotten a G6PD level before dapsone was started, which is the standard of care. It just got dropped, or maybe it was done actually at another facility, and we didn't have access to it, so we let it be on the safe side. So I'll just take a moment to summarize what we learned today, and then open it up to questions to you all. The premise of this entire spiel is actually down to Mariana, and seeing how she was very glad to see that the differential diagnosis of the patients with hip and back pain that we talked about was very, very narrow. And ultimately, her sharing how sifting signal from noise and balancing cognitive load and discharging and moving patients is one of the most important things that we do. And this is the analogy of that. This is not quite that, but this is all about managing cognitive load. And in a patient with shortness of breath and dizziness, you might be inclined to think about every single thing that can cause either of them together in parallel. But as you study medicine going forward, realize when you're merging things together, they're often not additive. They're often actually subtractive. And when patients have multiple things going on, your list shouldn't be broader. It's often actually much narrower. And what does the combination of dyspnea and dizziness mean? A patient who's dizzy and short of breath, the dizziness makes it impossible for them to have a lung problem. And the shortness of breath makes it impossible for them to have a brain problem. The only unifier here is perfusion, qualitatively and quantitatively. How do you get to the bottom of that? 3 simple bedside tests, an EKG, a point of care hemoglobin, and an EBG with co-oximetry. If those 3 are negative, your patient's going into the tube of truth because they probably have a pulmonary embolism. It's that simple. In 3 or 4 minutes, you can decide whether or not to get a CTPE rather than the average hour or 2 hours it often takes us. Why? Because this space is really, really narrow. Of course, there's a big caveat here, is your patient may say those words, dyspnea and dizziness. You have to be sure that that's what they mean. And this is where reps and reps in this space will allow you to follow the schema accurately. Alrighty, stop there before I make you all short of breath and dizzy. Questions, thoughts, concerns? Yes, Nicola, please.
I have two questions.
Hmm.
So I'm trying to build up my methemoglobinemia schema. I was just wondering about what are sort of the classic triggers. I had in my mind a patient, returning for endoscopy, having like lidocaine exposure, but I really liked returning from a dentist appointment also. What
Yes.
did you guys and girls maybe see? And then the other question was, I have this in my mind as sort of almost like pathognomonic, but I don't know how often it comes up that a patient with methemoglobinemia has like an O2 set that is stuck at 85%.
Yeah. Mhm.
Because this patient had like a 92, which was,
Mhm.
almost kind of throwing me off because I just, didn't have this connection.
Yeah, let me show you. I'll send you all a picture in the academy to show you the clue that I forgot to send you all. Yeah. I'm sending it to the academy now, so you can take a look at it about the O2 sat. So yeah, I think that most people with methemoglobinemia have one of three triggers. They either have dapsone or and anything that ends with a cane or a nitrate. Most of the time, people who get methemoglobinemia are because we prescribe them something, a cane, a dapsone, or a nitrate. Very rarely, patients can get it from laced street drugs with anesthetics or with nitrates. So yeah, I think dapsone, the canes, or a nitrate. I'll share with you a visual. I forgot what your second question was. I'm so sorry.
I was
Second
actually
question was-
reflecting on Nicola's second question, right? Like I put in
Yeah,
the
please.
chat because I was like, what is that? Like
Oh,
true
yeah.
hypoxia, false hypoxia?
Yeah.
But then I think it's like causing the low SpO2 reading, but actually patient would have normal PaO2, but the low reading was because of the hemoglobin structure like being altered in the RBCs. But regardless, patient does have tissue hypoxia. Sorry I don't know if I made it clear enough. Is that is my understanding correct?
100%. Yeah, absolutely. So I just shared with you the picture, so you can see in the vital signs that are charted by the nurse, his SAT is showing up as 93%, and yet the ABG at the same time, like minutes later, shows a PaO2 of 98%, which would predict a SAT of 98%. So there's a 5% what's called a SAT gap. The degree of hemoglobinemia correlates with the degree of the SAT gap. So what you're essentially looking for, Nicola, is that there's a difference between what the predicted SAT is and what it actually is, which tells you that the patient's actual oxygenation is fine, but rather there's an issue with you detecting it accurately, either because there's something external to the body that's impeding it, like nail polish, or there's something internal with the hemoglobin molecule, like methemoglobin. So any SAT gap is suspicious for methemoglobinemia. Most characteristically, patients will have a O2 SAT of 88%, but there's so many different variables that affect the O2 SAT, including how it's on the skin, the patient's skin tone, that you shouldn't be rigid to expecting it to be a specific number. What you're really looking after is a delta between what the PaO2 is saying and what the monitor is saying. And that gets you into the world of the DDX for a SAT gap. And the DDX for a SAT gap can be exogenous mechanical factors or internal issues. And internal issues, again, are perfusion or quality. Perfusion is the patient has Raynaud's. Quality is the actual contents of the blood. Really, really good question.
Thank you.
Yeah, of course. All right, y'all, go forth and conquer. And next time you hear somebody say that combination of words, I hope you'll remember the session and realize that you know, either you have an answer in 3 minutes or after you look and see the large pericardial effusion or the PE on the CT scan. All right, y'all. Nice to see you all. Have a great rest of your Saturday. Bye.